Welcome, everybody. Thank you so much for attending our Fireside Chat today. Very excited about being able to speak with Esther Schorr today. My name is Natalie Yeadon, and I'm the co-owner and managing director with Impetus Digital. For those of you who are not familiar with our company, we offer numerous cutting-edge synchronous and asynchronous virtual collaboration tools. And these tools can be used for a whole myriad of different purposes. As of late, since the COVID-19, a lot of people have been using us for the converting of their in-person meetings to, virtual ones. We use this for advisory boards, investigator meetings, co-author groups, etc. So at Impetus, we really believe that everything starts with a conversation, and sometimes big, hairy, audacious ones. So our online collaboration platform is a perfect place to start some of these conversations. But not only to start them, but to continue them. And to continue them is really the secret sauce. How do you make sure that you're continually engaging with people, instigating the conversations over the long term, and generating insights so you're developing authentic and lasting partnerships in that process? So as I was mentioning, having these big conversations is how we like to implement change. And ultimately, it's these 1% incremental changes, as James Clear says in his Atomic Habits book, that we create the inflection points or those exponential ways of disrupting healthcare. So with all of that said, the idea behind this webinar, this Fireside Chat series, is to start these conversations around some of these bigger, provocative, more controversial ideas and thoughts, and to discuss these opportunities that the healthcare industry is facing, or how they sometimes view this as being challenges. And we want to discuss how technology can help along the way. So without further ado, one of these big, interesting conversations is always around patients. And so very happy to have Esther Schorr online with me today. She is the co-founder and chief operating officer for Patient Power. And we're going to find out all about that organization today. And Esther is a skilled global project manager. She's worked with her spouse, Andrew, on this patient and family education project for more than 30 years. So that is amazing. And she has supported him in his cancer journey since his initial diagnosis with leukemia in 1996. So not only is she just fantastically involved in this education space, but also has experience with cancer and also as being a caregiver. So Esther is passionate about empowering care partners and is a strong believer that education leads to empowerment and better care. So very, very happy, Esther, to have you here. Thank you for your time.
Thank you. I'm very delighted to be here and to be able to have this conversation with you, Natalie. Thank you for having me.
That's beautiful. I was really intrigued when I sort of read about your history and where you got started. Intrigued by the fact that you started your career at Price Waterhouse and that you consulted for things like nonprofits, government agencies, financial institutions.
Yeah.
Kind of interested, like from starting off from there, how on earth did you ever evolve into the work that you started doing in the education space?
Oh my goodness. Well, I guess there are some people in the world who take a straight path to their passion. And I'm the exact opposite. I did the kind of weaving around a lot through my early life to come to what we're doing now at Patient Power. The sort of, I guess I could call them, people say, superpowers that I feel like I have, that's a through line through various kinds of things that I've done, is kind of what you mentioned. I love managing projects and multitasking. I tend to gravitate toward the operational side of organizations and tasks that I'm given, projects, and I sort of ended up in health education, I would say by default. I met and married a news journalist who you referred to as, I am his care partner. We met, and through a series of very strange circumstances ended up with contracts to do health patient education videos. And this was in the 80s, in the late 80s. I had actually been working outside of healthcare completely, got kind of tired of what I was doing. And Andrew said, well, why don't we start a business together? And let's see where this goes. And that's been the last 30 years. And his diagnosis with actually 2 blood cancers, going through clinical trials, etc., that just was a reinforcement and a confirmation that we both ended up in a field that we have some passion for and we have some experience in. So I can't really explain to you how I ended up here, but I did. And that's how we got here.
I truly believe that life is always conspiring for us. And so sometimes it's not the asking of why, it's just showing up and allowing these things to point us in the right universal direction. So it's a wonderful thing to many patients, I'm sure, that you decided to follow that track.
Yeah.
Now, it's interesting, you are a pioneer in the online patient education component. So that was very pioneering back in the days when you started that company called Health Talk. And so I was just curious, what were some of the key drivers to you wanting to start using online before it was even a thing? I guess, what were some of the motivators and what were you trying to achieve at the time?
Sure. And actually, the history of what we do goes back before what you referred to as Health Talk many years ago. And now I'm totally dating myself. When dinosaurs walked the earth in the late 80s, there really wasn't the ability to use the internet to communicate. And what happened was we started out as a video production company, and we were asked to produce some what are called linear videos for patient education. And what evolved was there became a need to use whatever platforms were available to reach more patients on a specific health condition. And I'll just give you one quick example. We piloted and used a conference bridge, like our conference calls without the video. We used a conference bridge to reach multiple sclerosis patients. And actually, I believe we did some work with the breast cancer community. Not just, it wasn't all oncology driven, but we figured out how to use a phone platform where people could listen in to, say, an hour-long program. They would hit buttons on a phone, remember when we had button phones? And we found that we could have like 1,000 listeners at a time listen to a live broadcast and then edit it so that people could punch in on their phone the pieces of the content that they wanted to hear. And so once the internet became available and video and posting things and websites, it was kind of a natural evolution. So that's how we ended up doing what we're doing now, which is using all the technologies that are available to us to reach more patient and care partner communities.
But, again, kudos to that, because that's a lot of resourcefulness at a time, like I said, when it wasn't a cool thing to do. And again, being a technology company ourselves, my business partner and I, starting this over 11 years ago, this wasn't a thing. And there was a lot of pushback at the time. And so it's unfortunately that, now post-COVID, that everybody's scrambling the door to convert their in-person meetings to online. But I do think it says something a lot about really being visionary. So kudos to you.
Wow.
I want to spend a couple of minutes talking about patient power.
Sure.
There's obviously was some years building up before it kind of reached that rendition. But tell us a little bit about what the company is, its mission, and what sorts of programs you create to instill some of that mission.
Sure. Well, the mission all along has been the same, no matter what platform we've been communicating. And it's basically to empower patients and their loved ones to take a more active and informed role in healthcare decisions that affect them. So we do that through programming. So when it's been possible, let's put the pandemic aside, we realize that there are people absorb information and have different information needs. So when it's possible, we do in-person meetings. We call them town halls. And the concept behind those is we get a couple of hundred patients and care partners together regionally. We often pair with a major medical center, and we bring those people together to inform them through a panel of experts, medical experts, researchers, and patients and care partners who can lend their perspective and support healthcare personnel. And it allows in that forum for patients and care partners to meet each other as well as ask questions directly of a panel. And those are then, as you're doing today, it might be it's recorded and streamed live and then edited so that people who couldn't make it to the event could benefit from the content that came out. We also do a ton of online content. So we do video interviews, we do Ask the Expert panels. We are now doing topical series on specific cancer topics where we'll have, it's kind of like a mini series starting from diagnosis all the way through psychosocial issues. We have added articles that are written by our staff, along with bringing in third-party content that fills some gaps in what we have. We're doing podcasts, and all of this is designed to cover timely, relevant topics in a variety of cancer conditions. We decided a number of years ago that there's so much need in oncology that we would just, rather than go a mile wide and an inch deep in our content, that we would go, well, it's not an inch, maybe a foot wide and a mile deep on selected topics. And we found that that model has worked well. And I guess the other way that we communicate is through social media and through e-newsletters. And those are mainly used for awareness raising of the content that we have on our website or events that we're doing.
So that's very interesting. So you're focusing, like you're saying, mainly in cancer, but multiple therapeutic areas then?
Correct. Right. Multiple therapeutic areas. We have historically had the deepest engagement in the blood cancers because honestly, that's where a lot of progress has been made in oncology. I can't say that there's any value judgment being made between us covering different forms of leukemia versus covering pancreatic cancer, but there are a lot of resources out there for pancreatic cancer patients. And unfortunately right now, there's not a lot of news. There's not a lot of new things happening there. And when there is, we will be looking to bring that to patients. So we look at ourselves more as a news source rather than ABCs of some particular disease state. I think the other thing that I'd just like to mention, Natalie, is that we've always been patient-driven journalism. That's what we call ourselves. Fully half our staff have been touched by cancer in one way or another. I think that's part of a gravitational pull that we've had in growing our business, but it's also because they totally understand the experience. They have their own network of people that they want to reach and touch. And so the spin, the topical things of interest, a lot of it is generated from the people on our staff who say, hey, I'm a breast cancer survivor, or my spouse or loved one has been touched by some other form of cancer. I know who the doctors are that are doing this, where the research is. Let's see if there's a gap in information, and let's bring that to those communities. So I think that sets us apart in a lot of ways.
There's been a lot of work and research and all kinds of other areas in clinical studies around rare diseases. Is that something that your group or company has been considering delving into, or do you want to holistically stay focused on the depth associated with the work you're doing in cancer?
I think it's a little bit of both, because just by the nature of the things that we've focused on, it turns out that a number of them are relatively rare. For example, we do have a breast cancer information area. We do have a lung cancer center, but a lot of the work that we've done has been in blood cancers, chronic leukemias, acute leukemias. There are a number of other ones that really would be considered in the larger scheme of things pretty rare. So we don't make the distinction, you know, of what we cover. I mean, admittedly, some of what we focus on is based on, and I'm guessing you'll ask me about that, is based on sponsorship. How can we fund developing that content? We do unsponsored content, and I'm happy to explain that. But we really go with where there is an interest, both from the communities and from our sponsors' interest in where there is research being done and new findings. So sure, we are happy to cover more rare conditions. There just has to be content there that will be relevant and a way to make it happen.
Absolutely. So you bring up some really great ideas here, that you're really a place and a venue and a safe haven, if you will, for patients to come to feel like they're going to be receiving relevant, compelling, and accurate data and information that's not going to be majorly biased in one way or the other. And that's what I call a safe you know, haven for them. Now, the other thing as well too is when we talk about the sponsorships, you know, having been on the pharma side, and I think there's a practical business evaluation to this. At the end of the day, a lot of times what we'll go through, and just very authentically and candidly here, that which will go through a sponsor's mind is, you know, what's in it for them. You know, they'll want to understand the database of customers or clients or people that are coming to the table. How do you profile that advantage to them? And you know, there has to be obviously that arm's length of not giving them, you know, because of privacy and data information. How do you share with them the benefits to the sponsor about what they're going to be getting access to?
Sure, no, that's a great question. Let me start by just explaining, because there may be people on the program, listening to the program, that don't understand. When I talk about sponsored versus unsponsored content, our sponsors are generally pharmaceutical companies who are looking to educate very specific audiences about their disease, about the disease that the people are dealing with. So what would first go through somebody's mind is, oh, well, they're coming to you to market their drugs that are either in pipeline or they're marketing. We have a very, very clear and ongoing sort of iron curtain, maybe that's a bad word to use, a wall between what the initiatives are that pharma has around marketing a drug or marketing awareness of a pipeline drug and what we produce. The money that is given to us to produce content is given at arm's length, as you referred to. They say, look, we're working in this area to develop drugs, or we have drugs for, let's say, leukemia, a certain form of leukemia. And they say, we know, Patient Power, that you have a following of X number of thousands of leukemia patients who come to you for fair, balanced, complete information about what current treatments are available, what treatments are coming. We will give you some money to simply educate people about what their disease is, what the current treatments options are, and what questions they should be asking their doctors. So what pharma knows as a sponsor is they're going to reach the people that could simply ask the question about their drug, other drugs, about other treatment options, about clinical trials. And we are always very clear at the outset that that's what the relationship is. So the interaction with pharma is exactly that. We do also do unsponsored content, which means that we're very dedicated to covering not only very specific topics around diagnosis and treatment, but we also know that patients and care partners want to know how to get through those periods of, you know, unknown outcomes and the psychosocial issues that come around. I have cancer, or I'm dealing with somebody with cancer. How do I manage that emotionally, psychologically? How do I live a full life? So those are things we just do because we feel it's important.
Absolutely. And it fills out the whole equation. And again, it fosters that authentic relationship and partnership and trustability and credibility.
Exactly.
So I want to just kind of linger a little bit more on the opportunities as well as we think and project further on. I
Mhm.
think historically, there has always been a bit of a single-sided conversation that I think historically pharma has had, even if it's done at arm's length. It's a little bit of, here's data, please disseminate it to your physicians and ask XYZ question. I
Mhm.
think in the new environment, with the advent of technology, I
Mhm.
think that conversation is changing. Pharma has coined the phrase patient centricity. So it's become kind of popular. I think sometimes pharma has talked from two sides of their mouth and hasn't really employed anything. It's just been more jargon. But I do think over the years we're seeing some real frankness and some realness behind that use of that word.
Mhm.
So have you seen a little bit more of a dialogue now as opposed to a single-sided conversation over these past few years?
Absolutely. So, we talked about 30 years of talking about health and educating people. And during most of that time, we have dealt with pharmaceutical companies as you said, arm's length partner. What I've seen clearly over the last, I'd say, 3 to 5 years is a real evolution in that dialogue. So a few things have happened. We attend medical conferences and we talk not only with medical experts, but we talk with the vendors who are there, the pharmaceutical companies. And yes, patient centricity comes up. But what we're seeing is we're being approached now with great regularity by pharmaceutical companies to help them understand what's called the patient voice, to understand how they can be more responsive in their development of drugs, in their way that they communicate about health literacy. How do they get people to understand the pros and cons of their treatments? They're sort of, they're just wanting to be more educated and bring patients into that. I can tell you that another aspect of our business clearly shows that openness. It's sort of like this door's been opened. We do something as part of our work called patient engagement. And what that is we have some staff who work directly with pharma, and a pharmaceutical company will say, we're developing a clinical trial for X disease to help treat. We're got a new drug in pipeline and we've got to design the clinical trial. We want to talk directly to some patients who have been on one of our earlier drugs, or are in a clinical trial for similar drugs, or they may say, we want to talk to some people in our clinical trial, or somebody who has not yet been in a trial or not yet on treatment, to understand their experience. And so because pharma has regulations, as you well know, they can't reach out to patients directly and say, hey, come on, we want you to talk to us. They come to us. We have some specialized staff, and they essentially make a partnership. They make a relationship. We obviously get permission from the patients who are from our community. We introduce them to the pharma folks of interest, and they get in a dialogue directly about what their experience is, what are the problems with a clinical trial that requires them to travel, why do we have to have infusions instead of an oral drug? We could go on forever, but the point is, we're seeing even in the evolution of our business that pharma is coming to us and saying, we want to engage with patients and understand so we can plan more appropriately. So that's a really long answer to, I've seen incredible progress in that regard.
That's a beautiful, beautiful thing. Very interested to learn more about, obviously we would be remiss not to talk about COVID-19 and what the, hashtag new normal is going to be all about, especially in the world of patients, clinical studies, clinical trials, and just pharma in general. So I guess, it's really kind of getting an understanding from you about some of these earlier discussions about the utilization of patients in clinical trial development, clinical trial inclusion, and what you predict are going to be these key changes. Now that we've seen what's happened, how do you predict clinical trials might look like in the future post
Oh,
COVID-19?
well, um, my sense is from what I'm seeing, cancer patients are in the highest risk groups. Most of them are immune compromised. So to ask a cancer patient to enroll in a clinical trial, to get on a plane, to come to whether it's their regional medical center or to a clinical trial site, even post-COVID, is going to be fraught with a lot of fear. And then, people are going to say, I'm not going anywhere. I'm staying home until we know that there's a vaccine or a way to treat this. So I think, and I know that these conversations are going on already, I think that those pharmaceutical companies and other groups that are running clinical trials are going to have to get really creative. One of the ways I would think is, we're seeing telemedicine developing. So telemedicine right now it's been around for a while, but it's triaging a lot of instead of coming to an emergency room or coming into the clinic, is doing basic diagnostics. With a clinical trial, I could see that if there is a patient who is a prospective person on a clinical trial, that the initial screening, who you are, what are your symptoms, what's the treatment that you've already been through, et cetera, that can all be done through a telemedicine kind of format. Then I think the trial folks are going to need to say, okay, can we administer our trial drug either through partnering with a local clinic that has precautions in place that a patient will be comfortable with, and have the patients go there? Or can it be administered at home? And then there are telemedicine check-ins on symptoms. Some of it is going to be impossible to do that way. And I don't really have an answer to that, because I know, having a spouse who's gone through 2 clinical trials, with one of them, the initial trial administration was real rocky. After that, it was easy. He could have done it at home. But so I think there's going to be a balance between what can you do and make patients feel reassured that they're cared for in the way that they need to in a clinical trial. And at the same time, realize that some clinical trials, they're not going to be able to do that way.
Yeah, absolutely.
I think
Very interesting.
the one other thing that I think has to be recognized, especially when you're talking about clinical trials, is that right now financial concerns for patients is huge. A lot of them have lost their jobs, or their spouses or their loved ones have lost jobs. If they're going to participate in a clinical trial, how are things going to be paid for? If they have to travel, how's that paid for? They're at high risk. So they have to think about that. How can they supplement on the financial side to help people feel comfortable that whatever needs to be done in a clinical trial can be done safely and with some financial support that might not have been there before?
Yeah, so a lot of really important points you brought up there. And all of these are pointing in the direction of, or pointing to the fact that a lot of these phase 3 clinical studies that we have, that we are doing from a legacy standpoint, need to be clearly reviewed, because, not only for cancer, but just across the board. I think one of the things that we keep hearing over and over is that the clinical endpoints are very brittle and they're very fragile.
Mm-hmm.
So what would be ideal, I think, in the future is being able to see clinical studies that are location non-specific, meaning sometimes they can be done in the clinic and sometimes they can be done basically in the choice of the patient. Sometimes they may, for Christmas, they may want to go into the clinic because their home is busy. And other times in the summer, they might be snowbirds. They may be living in another country, that it's, they want to be able to, or should be able to, have choice. And that requires a huge amount of scrutiny and review, and being able to come up with, we hear this word a lot nowadays in COVID-19, post-COVID-19 days, but resilience. It's not just about efficiency and efficacy. And, there's another component around resiliency.
Mm-hmm.
So how do we create resilient clinical trials? So that's actually a really interesting component to think about how to provide that for patients moving forward.
There is another point, if I could just throw it in,
Absolutely.
is that access to clinical trials is a really big deal. I mean, we hear, as you probably do, that there are demographics globally that pharma would love to have in their clinical trials to be able to prove efficacy across broad groups.
Right.
And right now, we're seeing it with COVID. There are ethnic, cultural groups, economic groups that simply don't even have access to information or existing drugs. How do we get them access to being involved in these trials? So it's really going to be a Herculean effort and a partnership between, I think, pharma and local and regional organizations, advocacy groups, groups like yours that focus on communication, to figure out how you're going to broaden the pool of people that you can have involved in a clinical trial, move it forward, and know that your drug is going to work essentially for a global group of people who are dealing with the same illness. But it's complicated.
And I think it's a really interesting question, because I think now getting away from the rigidity of density, i.e. in real life, IRL is a term that I've been hearing thrown around lately. When you start going into the digital space, suddenly the globe has opened up to you. And so the question comes down to redundancy of clinical trial sites. Does it make sense that there's a centralized clinical trial review area? Should these things not be reviewed centrally in some sort of national or global enterprise? So this idea of having these central, these centers starts to make you ask those questions. And one of the pivotal pieces to that, I believe, Esther, has to do with electronic health records, having access and the interplay and the flow of health data. And here's the other question I want to ask you on that is interoperability, not only within institutions, but regionally, nationally, globally, as we continue to expand that as an opportunity, but also in terms of making these patients digital citizens, being able to allow them to have the access and the wherewithal and the ability to understand what data they want to own and what data they want to share. Do you have any thoughts on any of that?
Well, yeah, and I do know that it's an ongoing debate about who owns patient data. I have my personal records. I share them with my personal doctor. At what point is my information relevant to a bigger good, or my husband's experience with a clinical trial and good outcomes that he's had versus bad outcomes? That's the way, maybe it's a bit of a diversion, but within the COVID space, my understanding is that technology is for the first time allowing doctors and researchers to share experiences, even if it's not named, but share patient experiences and their experience in treating, in order to not duplicate efforts. So I think to answer your question, I think that both patients and healthcare systems are going to have to figure out what's the balance between patient privacy and being able to share some level of data to move research forward and to be able to improve outcomes. So the dialogue is going to have to happen about who owns the data, what's the purpose of sharing some level of data, and who has the choice of, does a patient have a choice of sharing it, or does it become a global responsibility to share some of that data? But it's also going to be a cultural shift, because people value their privacy and they also don't want repercussions. We could talk for an hour about that, but there are patients who are afraid that if their workplace knew somehow that they were a cancer survivor, that their livelihood would be at stake, or that they need to go into a clinical trial. Can they get paid time off to do that? So I think technology is fabulous, but there are going to be some very tough discussions that are going to happen, or patients are going to have to give, and systems are going to have to give to figure out what's the right balance.
I think that you raise a really great thing, and I like to oftentimes refer as systems innovation. So systems thinking, getting beyond the one incremental little things and dots and things that we do all across the country, and looking at this much more thematically and systematically. So that is about design thinking. I think that, you know, these are all really important questions as we figure out where patients play, et cetera. But one of the other things I thought would, you know, and again, I know that you have some Microsoft background and obviously some huge interest in technology, but I'm very intrigued by the possibility of blockchain technology in the sphere of electronic health records, the world of health data sharing, et cetera. So here's something for consideration. We talk a lot about UBI. We talk about, you know, what is this new world going to look like in the space of robotics and automation. So as we think about it, data is the new gold. It's the new fuel. It's the new oil. Health data is part of that. And so if we can start to foster education, this is something that your organization can probably help disseminate, in the digital charters that are available. What is digital literacy? What does it mean to be a digital citizen? What is ownership versus sharing? I've heard stats that 9 out of 10 people are willing to share their data. Is how do we assimilate or bring up UBI versus sharing your health data? So if we use, for example, blockchain, and we leverage the concept of the 6 Ds, which is, you know, digitization, deception, dematerialization, demonetization, and democratization. How do we democratize data? If we leveraged a blockchain system and patients are tapped in that, or their health data is, just like a YouTube video, if you become a popular YouTuber, every incremental time somebody shares or uses or watches your video, you get paid. So I bring this in with UBI, is that yes, we might have a day where people are not doing quote unquote useful or high value GDP oriented work, but they still can get paid by creating and leveraging value, emitting health data in the blockchain. And every time a researcher or somebody is looking at their data, or somebody is talking about their data, presenting their data, they get that little currency each and every time, and they get paid for their data. So I was just curious about your thoughts on blockchain or any of those concepts I just shared.
Well, I'm going to be the first to admit I'm not an expert on blockchain. I know conceptually what it is, and I understand your question. And what I do know is that I have had discussions with a number of patient advocates who are very active in social media, have published papers about advocacy and in the area of data sharing and data ownership versus being able to share it, etc. And one of the recurrent themes is, okay, I don't have a problem with sharing data, but I do feel like, in a sense, my data is contributing something to the greater good. And yes, I have financial things that I need to take care of. Being, in a sense, spiffed for that data or paid for it makes sense as one piece of the puzzle. But I think the biggest challenge with what you're talking about is going to be educating patients where they are at the level that there are of literacy, of understanding technology, of understanding privacy versus the reason to share certain aspects of it. It's going to be a big health literacy challenge. So yeah, I'm not saying it can't be done, but I think pharma and organizations like ours, like yours, like advocacy groups, like, I know like research foundations, if we can come up with, work together to come up with how to explain this to people so they understand what they're being asked to do and why, I think it can work. I just, there are a lot of people in the world who simply don't understand how Zoom works or why it works, or when you transfer data from one place to another, where does it go? It goes into the cloud. Well, is there a cloud up there that's got a bunch of sentences in it? Or, what I just think there's a lack of understanding. The ideas you're talking about are ahead of where people can comprehend it. And if we can work together to help people understand it and what the benefit to them and to other people are, I think it can work.
Yeah, absolutely. And I have some other thoughts as well too about what the world will look like in the future as it relates to pharma and what the pharma business model could look like. Today, we see multiple different multinationals all existing in their own space, just like, you know, their own limited silos, doing their own clinical trials, coming up with their own drugs. Suddenly, if we democratize data and we start creating these shared data lakes, right, eventually data oceans, okay, is when we tap into this, the question comes down to is what is a pharmaceutical entity? Is it a group of researchers or interested clinicians who come together around a pivotal problem? Regardless of what organization they happen to work in, they contribute, they aggregate together to create, even if it's a finite entity, to solve a health issue. So the fluidity or the boundaries around what a physical pharmaceutical company could change in the future. And so the bigger question around that is around access to these data oceans or data lakes. Right now they're just lakes. And you know, how do we reinvent some of the legacy infrastructure and the legal and the compliance, because there's a sense of rigidity and density around that. COVID-19 has accelerated, it's been an accelerant for some of this pivotal thinking, but we're certainly nowhere near, you know, breaking down some of these boundaries. I'm just curious about your thoughts on some of that as well.
Well, I think you hit on some real things that are already happening. If you think about it, the model that is sort of just happened as a result of this pandemic crosses the existing infrastructure barriers, maybe not specifically with pharma, but we're seeing it for sure in medical institutions. So we know from talking to experts during this time that a doctor, an oncologist, or a researcher at Johns Hopkins is talking to an oncologist or researcher in China at the Chinese Institute of whatever, and they are sharing through social media, through tweeting at each other, through WhatsApp, through exchanging emails and health episodes with their treating patients with COVID in order to come up with the protocols for treating people moving forward. So they're already breaking down those barriers. I don't know if you want to go down the road in this discussion of our model for pharma here. We're in the US, and the multinational version of that is pharmaceutical companies compete with each other. They're for-profit entities. And I'm not going to go there about whether I think that's a good thing or not, but it presents a much deeper issue of what those entities are willing to share, because when they share their certain kinds of data, they're jeopardizing the capitalistic part of it, or the financial aspect of being the group to find the cure or the vaccine or whatever it is that's going to move medical science forward. So, you know, if we're becoming a global society impacted by global health issues, somewhere along the way, I think the model may need to change. And some of that, I think, may happen as a result of patients advocating for the very best healthcare they can get. And they're going to say, that group over there, that pharma company, that small clinical research group is doing this, X, you're doing Y. I think I can see that if you put those two pieces together, it's going to help me as a patient. So that's going to be dialogue that's going to have to happen. I think some of it is starting, but it's a big nut to crack.
I have one more big airy-fairy concept before I bring it back down to earth. But one of the other things I think is really intriguing for possibilities of the future are the potential, you know, we talk about positive disruption, and this is, I personally believe, in the greater scheme of things, is a positive thing to happen. Disruption means gestation and, you know, of newer things. And, you know, an incubation of new things. And so one of the opportunities is potentially some replacements of some of the brokers things like clinical research organizations or IDNs or even the investigator. Let's just say theoretically patients, now that we have new potential, more nimble endpoints, let's just say theoretically that we're starting to create those, people have access to sensors. Let's just, move ahead in the future and talk about things that are embroidered in our clothing. Or, we launch eventually the tricorders that can now sense all kinds of things. You cloister around yourself using social media, other people who have a similar metrics, health metrics. And then you use crowdsourcing to fund your own clinical study. Patients can suddenly become their own clinical research organization.
Mm-hmm.
Do you see that as being a possibility, or is that really sci-fi?
I mean, look, 30 years ago, we thought the internet was sci-fi. I think anything is really possible. I think that there are more psychological barriers than technological barriers at this point. I mean, when you talk to somebody on the street about artificial intelligence, unless they're technically savvy, they kind of go, oh, I don't want a bunch of robots running around and, that I don't know if it's human or if it's a robot, The biggest barrier is going to be for people to understand the motivations behind moving technology forward. And I think that's a bigger challenge than the technology itself. And I think we're going to have to take baby steps.
Absolutely.
I think we're going to have to take baby steps on this. And again, I think the people who can help move things forward, I think are going to be the patients, patient advocates, care partners, organizations like yours, perhaps organizations like ours that have credibility amongst patients and groups that support them to say, you know what, there is good in this, and let's go down this road together and be sure that be sure that we flag things we're not comfortable with and figure out whether there's really something to be worried about or not. So I don't think it's sci-fi. I just think that it's going to take time.
I love it. Love it. Love it. So bringing things back down to earth for a few minutes here, again, a lot of us are emerging from, our self quarantines and, businesses are starting to open up. What is your hope for the near future? What do you think things are going to look like for your organization, for the patients that you support? What is your hope for all of that?
Well, my big overriding hope is that medical science comes up with, if it's not a vaccine that will protect all of us, that they come up with a way to manage whatever this virus is and future viruses, so that people along the whole spectrum of their current health can feel comfortable with social interaction again. I think there is a lot of sociological and psychological and emotional damage that is going on right now by having everybody locked down. I totally understand it from an intellectual standpoint. We're waiting for medical science to catch up. They just, the safest place for somebody who's immune compromised right now is being at home, or if they have to go out, wearing a mask and staying apart from other people. And we're asking other people who are not at great risk to do exactly the same thing. It's very difficult. So I'm hoping in the near term that at least medical science catches up enough so that we don't end up with a society where you have the people who have to stay at home because they're terrified of going out and getting sick and dying, and people who have the antibodies who are generally very healthy and they go about their business. So there's a lot of work to be done there, but my hope is that will come sooner even than a vaccine. Let's figure out how to manage this. And I also think that in the near term, our organization and organizations like ours need to continue to reassure and educate patients as there's new information, so that they and their families aren't terrified. They're very afraid right now. And we've always believed that information is power, so patients have to advocate and ask their questions and get reassured about what's safe to do and what's not safe to do.
Love it, and great segue, hence the reason for patient power. That's an important area. I'm sure that a lot of people who are listening to this would probably love to get in touch with you to find out, A, what's happening with cancer, hematology patients, CML patients, what have you, and see if there's things they can do or what they need to be doing post-COVID. How can pharma companies get in touch with you if they want to have some discussions? Where can they reach you?
That's easy. They can first go to patientpower.info, INFO, and anybody is welcome to contact me directly at Esther, ESTHER, at patientpower.info, and I'll connect them with the right people within our organization to discuss our capabilities and, just have a discussion about the kinds of things you and I have talked about, and more specifically, how we can help pharma do the education and the outreach and reach the people they need to reach. Happy to do that. And I appreciate the opportunity to speak with you and with folks that have that interest.
Beautiful. It has been an absolute pleasure, Esther. For those of you who are listening to this, either now or afterwards, Impetus wants to thank all of our audience for paying specific attention to some very important and intriguing topics for the future. As I was mentioning, Impetus Digital has created some of the best-in-class asynchronous and synchronous collaboration tools. Just like this conversation with Esther, we're here to be the bridge for these courageous, provocative discussions to help move and positively disrupt healthcare for the future. So we'd love to have a conversation with you as well. Thank you so much for your time. It was wonderful speaking to you, Esther.
Thank you, Natalie.
Thank you so much, and wishing everybody a wonderful day ahead.